Good morning, everybody. Welcome to Grand Rounds. Thanks to those of you who are in the room with us and those of you who are online. Today I have the pleasure of introducing two wonderful speakers from Seattle Children's, Dr. Hannah Deming and Dr. Elena Griego. Dr. Deming is an assistant professor in the Division of Bioethics and Palliative Care and a member of the Truman Katz Center. She's also an associate program director for the Pediatric Residency Program at the University of Washington. In this role, she focuses on our recruitment processes and has been instrumental in redesigning our selection process. Dr. Elena Griego is a clinical associate professor in the Division of Hospital Medicine. She's also an associate program director for the Pediatric Residency Program at UW. In this role, she is guiding our program through transitions in assessment models and curricular structures. Thanks to both of you for being here. Welcome.
Thank you all so much. So our disclosures is we have none. And these are some of the objectives or key things we hope you will walk away with, but the big picture is that things have been changing and we expect them to continue to do so. We want everyone to have an updated sense of the challenges in pediatric trainee recruitment and major updates to pediatric med ed that impact each of us regardless of our role. We're going to cover this first by talking about workforce trends that we're in particular seeing in our trainee pathway, and then Elena is going to share with us about medical education innovations, and then I'll return to discuss some specific next steps and action that each of us can take. So in terms of the workforce, I want to acknowledge that some of the data I'll present is not always the most beautiful, and I realize that that is something we are facing a lot in our day-to-day lives. And at the same time, I do think that awareness and understanding is a key step in us being able to address the things we see and to be able to take steps in our daily practices to help shift the trends in the ways we hope. So back in 2013, the American Academy of Pediatrics warned of a shortage existing in many pediatric subspecialties and inadequate distribution of primary care pediatricians in rural and underserved areas in particular. Since then, the research around rural pediatric primary care has further increased worries in this area. From 2010 to 2020, the overall number of general pediatricians has increased, though it's uncertain if that is at a pace that is necessary to keep up with patient needs nationally. But regardless of that, the availability of pediatric primary care in the rural setting has gone down in that time. Additionally, family medicine physicians in rural areas have also decreased, so they are not in a position to fill that gap. In this time, there was a 10% increase in the number of counties with neither a general pediatrician nor a family medicine physician, meaning many children in rural areas have even less access to pediatric primary care than they did a decade ago. When we look at the pediatric subspecialty space, and fast forward to 2013, the National Academies issued a over 300-page report on the pediatric subspecialty workforce, which was chaired by our own Dr. Fred Rivara. And there's nothing quite as intimidating as talking about grand rounds with something that Dr. Rivara has been a big part of. But importantly, this report found critical shortages of many pediatric subspecialists and that these shortages were affecting the care of children. For example, they discussed families waiting 6 to 9 months for appointments, traveling long distances for specialty care, and their health outcomes being impacted. The report highlighted the need for increased attention on our recruitment into these fields and the need to rethink how we best deliver subspecialty care in general. Affiliated with this NESM report, a team put together a truly remarkable model to forecast the workforce in many of the pediatric subspecialty fields. They did not detail hospital medicine, given its recent change in boarding requirements made that field less reliable to model, but I'm going to kind of walk you through the results for the other specialties. So the first column is the specialty. The next is the total headcount, or how many physicians were practicing in that field in 2020. The next column is the total clinical work equivalent per 100,000 children, and that's where they tried to account for people being part-time or doing clinical research as opposed to clinical time, and their model actually even accounts for shifts in people being part-time more often. And then the last column is the change that it was anticipated in clinical work equivalents per 100,000 children from 2020 to 2040. And the key finding is that the projections found the current training capacity, will be insufficient for most pediatric subspecialties. PICU is the only pediatric field that is at concern of physician oversupply, with cardiology being in a strong place. But we all know how much our PICU and cardiologists love their infectious disease consults, and that all of these other fellowships impact all of us. Additionally, while some fields have been consistently in a place of struggle, there's also shifts in others. So the authors provided a descriptor to try and capture what is the workforce projection, as well as what is the projection in care needs, and to describe where are things at and where are they heading. And some of the descriptions are pretty hard. For example, for nephrology, they describe it as a field that is currently under strain and with a future workforce projection that appears bleak, is their word. And neurodevelopment they call out as being a field whose workforce is currently and in the future projected to be in crisis. Some other fields, like emergency medicine, have okay total numbers across the nation, but significant geographic disparities that are anticipated to worsen. So for example, emergency medicine, there's currently no pediatric emergency medicine doctor in 4 states, including Alaska and Wyoming, and there's only pediatric emergency medicine doctors in 1 county, in Idaho and Montana. So that's 4 out of our 5 whammy states that don't have, or that are qualified as a PEM desert. What really keeps me up at night is a lot of these projections are based on an assumption that resident pediatric trainees medical students will continue to choose pediatrics at historical rates, and that if we were able to find ways to increase the number of pediatric trainee positions, those spots would fill. However, when we look at the national data, I have concerns that that's not what we're seeing. Fewer people nationally are applying for pediatric residency positions. From 2014 to 2024, there was a 2% loss in pediatric applicants per year, and that's despite the fact that there was growth in the overall number of residency applicants. So there's more medical students who are going to residency, but fewer and fewer of them are picking pediatrics. Additionally, pediatric applicants are increasingly cross-applying in other fields, which is further reducing the functional number of applicants we have. So in the preliminary data for this cycle is that 52% of pediatric applicants applied in at least one other specialty, often using pediatrics as a backup for if they don't get into their preferred field like derm, OB-GYN, or psychiatry. Additionally, these numbers are thought to be dramatically different than pre-COVID, when people did this much less often. And so in combination, I think we've reached a tipping point where we can no longer count on filling new spots in pediatric residency programs, even if we find funding for them. In 2024, pediatrics had its lowest fill rate in modern history at 92%. As a national field, we left 268 residency spots unfilled, and 30% of programs across the nation didn't fill completely. 2025 fortunately showed a moderate rebound, but we still aren't confident in what the future holds for us. And while our program remains strong, and thanks in large part to the amazing people in this room, we have continued to fill, our internal data shows that these trends are impacting our recruitment metrics as well. So then let's looking at who is no longer applying in pediatrics. And one of the big groups is US graduates are showing less interest in our field. So there's been a significant decrease in the number of US DO grads and MD grads applying into pediatrics. Fortunately, this has been partially offset by an increase in the number of IMGs who are applying in our field, which has been really key for keeping our numbers stable. It also appears that there is a declining number of male applicants into pediatrics and that this is contributing. The ARIS does not readily provide gender data at the applicant level, but when we look at the American Board of Pediatrics data on the number of interns, we see that there are fewer men in pediatric residency today than there were in 2020, even though the absolute number of residents is up. And the challenge in pediatric trainee recruitment extends into pediatric fellowship recruitment. In my analysis, I went through the pediatric fellowship matching trends from 2016 to 2025 across 15 subspecialties. Again, didn't do hospital medicine because it's got weird shifts in the meantime. But in 2016, we had almost exactly as many applicants as fellowship spots, putting boxes in green and our match ratio dots above the 1-to-1 green line in our graph. By 2025, we had a significant overall shortage with only 0.8 applicants per fellowship position available. And that means that the black dots of our average match ratio and its trend line have drifted further and further below our goal of that 1-to-1 green line. In 2025, there is an overall total deficit of about 400 applicants across all subspecialties combined. Some of that worsening of the ratios has been driven by an increasing number of fellowship spots being made available. But again, I think this overall message is that at this point, recruitment into our training programs is a major rate-limiting step to us being able to address our workforce issues. And so why is this happening? Well, in some ways, we don't really know. There's not a lot of good research into how medical students think about their careers, in particular in pediatrics, and especially we don't have good studies that talk to med students who at one point were considering pediatrics and then decided not to go into the field. At the same time, there's a lot of data pointing to money being a key driver of this story. So let's talk about the money because the economic factors are quite striking. While pediatric salaries have increased over the past decade, they have not kept up with medical student debt. In 2024, the vast majority of US med school graduates had debt, and on average, it was almost $250,000. About 25% of med school graduates that year had over $300,000 in debt. Additionally, as we all have been experiencing daily, the cost of daily life has grown faster than our salaries. And while it's old news that neurosurgeons make a lot more money than we pediatricians do, I think it's hard to fully grasp how much more our internal medicine colleagues are making than us. A study found that in present dollars, the average internal medicine specialist will make 25% or $1.2 million more over the course of their career than their pediatric specialty equivalent. That goes up to $2.2 million for our pediatric GI colleagues. Further, many other areas of medicine have had faster increases in their salary over time than pediatricians, making this gap wider and wider with time. And so while there's limited research into talking to US med students about what factors impact their career, there is some data to give us a sense. This is looking at the AMC graduation questionnaire, where they asked respondents to rank factors on if they had a moderate or strong influence on their specialty choice. And we see that overall US med students report that money plays a low role in their career decisions, but we can see from 2019, those gray dots, to 2025, the green dots, the impact has been increasing, and it's actually some of the biggest shifts in their study are med students reporting money being a bigger driver than it used to be. And while many medical students say that money isn't a top driver in their career decisions, when we look at pediatric subspecialties and fellowship match rates, it certainly looks like compensation matters. So the graph on the left shows how pediatric lifetime earnings change when people do a subspecialty instead of pediatrics. It's okay. And the first thing we see is that many people will have a lower lifetime earnings despite having done a fellowship if they do a subspecialty instead of general pediatrics. And then we also see that subspecialties that pay more, like cardiology, critical care, and NICU, tend to fill more than the fields that have lower compensation. So I personally wonder if maybe money is impacting medical student decision-making more than we hear in the studies. And I'm sorry you're all hearing me twice right now. There you go, better. So one of the studies we do have is they went and asked a group of pediatric interns why they went into the pediatric field. And they were consistently transparent about being aware that pediatric salaries, prestige, and even free time aren't the best compared to other fields, but they chose it anyway out of a dedication to their intrinsic guiding principles, like doing what you love, and their alignment with the values of this special field. And the research shows that many of us are still drawn to the field of pediatrics out of these values. A survey found that 74% of currently practicing pediatricians cite their passion for this specialty and sense of missions as reasons they stay in the field. And I think this is one of the things that makes being a pediatrician the best. It is really incredible to be surrounded by all of you, people of deep passion and strong mission. However, I fear that as the money has gotten worse and worse in our field, an increasing number of medical students with similar passions and values are being boxed out of this incredible opportunity because they can't afford to make the same decision we did. So what is being done about this? At the national level, the Association of Medical School Pediatric Department Chairs has created a workforce initiative with 4 key pillars that is based off of the trends we're seeing. First, they're doing work on economic advocacy to try and improve pediatric reimbursement. They're also doing work to improve support for pediatric researchers because a lot of the numbers I cited are even glimmer when you look in the pediatric physician scientist pathway. They also are looking into practice collaboration and how to optimize care models to better support our pediatric subspecialists and patients getting the care they need. And then they're also looking into ways we can redesign our education system to improve the training experience and recruit more people into pediatrics. And I'll pass it on to Elena to talk more about that.
Thanks for all that information, Hannah, and definitely gives us food for thought. And while we think about our future colleagues, we also have to spend a lot of time thinking about the folks that we are lucky enough to work with every day. So as we consider these national workforce trends and work to recruit more amazing medical students into the field of pediatrics, we need to consider how we can design schedules that better support learning and well-being. Let's turn now to the evolving scheduling models designed to address these needs. So until recently, a traditional block schedule was commonplace in pediatric residency training programs. Under the block schedule, residents moved between rotations about every 4 weeks, while also going to continuity clinics sometimes once a week, sometimes twice a week, and other times every few weeks, with the goal of attending a minimum of 36 half days of clinic over no fewer than 26 weeks, so about once every other week. And now imagine having to build an extensive travel time when moving between clinical sites throughout the greater Seattle area, as shown here. This is a map of all of our continuity clinic sites for our residents. This often results in missed clinic and inpatient teaching, fragmented inpatient care with rushed handoff of inpatient responsibilities, inconsistent clinic days and preceptors to accommodate scheduling, and ultimately conflict between inpatient and outpatient training. This was the reality for our residents under our old model. After many years of planning, the ACGME updated their program requirements for graduate medical education and pediatric residency, which became effective in September of this past year. While there were many changes that I'm not going to bore you with, the overall emphasis really put an increased emphasis on ambulatory training and individualized curriculum, changes in how requirements were counted, and new rotation experiences, including required training in mental health, outpatient subspecialty exposure in the first half of residency, hopefully to try to address some of those fellowship gaps, and a focused general ambulatory pediatrics rotation that is outside of the longitudinal continuity clinic requirement. Under these changes, educational experiences are now counted in weeks, where 1 week consists of a minimum of 8 half days of educational content. This change requires more robust and consistent presence of residents on electives and outpatient rotations, necessitating a reimagination of coverage models and educational opportunities across the 3 years of training. While the requirement of 36 half days of clinic remains, these sessions can now be distributed across the year differently, occurring at a minimum of every 8 weeks, which allows for implementation of what has become known as the X+Y scheduling model. In the most simplistic terms, this model separates what we consider concentrated clinical experiences, or X weeks, from longitudinal experiences, which include things like continuity clinic or Y weeks. Rather than leaving one clinical environment for another, like under the old model, under this model, residents are able to focus on one specific educational experience at a time, reducing the cognitive load of switching between often very different clinical settings in the same week or even day. To ensure consistent patient care throughout the year, under the X+Y model, residents are divided into cohorts, with residents rotating on and off of a service or rotation every week, rather than everyone switching on the same day every 4 weeks. Despite being new in pediatrics, the concept of X+Y scheduling has existed in other graduate medical education programs since the early 2000s, when it was first piloted in internal medicine, with popularity really increasing throughout the 2010s. The most recent survey of internal medicine programs from 2018 reports that almost half of internal medicine programs were using the X+Y model, with multiple published studies since that time suggesting a variety of improvements to the medical education of trainees. In 2018, 5 pediatric programs participated in the first pilot of X+Y scheduling in pediatrics, which continued to expand over the next 5 years, with a total of over 20% of pediatric programs participating at the time that the pilot stopped enrolling in 2022. With the change in the ACGME program requirements in 2025, particularly the changes related to counting requirements by weeks and the number of weeks of clinic each year, X+Y became a viable scheduling option for our residency program, and we officially implemented this model in July of 2025. Because internal medicine has been doing this for a lot longer than we have, there is a robust body of literature exploring the benefits and challenges of X+Y scheduling, the themes of which we've tried to summarize here. While there is some mixed data on the true improvement of continuity within clinic and what that actually means, the more recent data suggests general improvements in continuity related to consistent clinic days, improved predictability, and improved regularity of resident presence in clinic. Additionally, in numerous studies, X+Y scheduling improved resident focus on outpatient education, improved resident satisfaction with ambulatory training, improved patient access to care, led to fewer interruptions in clinic, and a resultant overall increased interest in ambulatory internal medicine. In addition to the benefits of learning in the outpatient setting, residents also report less fragmentation in care delivery in the inpatient and outpatient settings, resulting in fewer inpatient handoffs, significant reductions in competition between inpatient and outpatient responsibilities, and improved sense of patient ownership. Some of the challenges encountered by programs include the staggered start dates for residents, which result in less time as one cohesive team, the need for increased redundancy in teaching points to ensure all team members have the essential baseline knowledge, and a higher frequency of onboarding needs. Additionally, there can be challenges scheduling frequent interval follow-up for patients who need to be seen more frequently than that Y-to-Y interval allows. On a program level, the X+Y scheduling model allows programs to customize the balance of X weeks to Y weeks to meet the needs of their program, allowing shifts between the balance of concentrated and longitudinal time. The trade-off is a substantial increase in administrative complexity for scheduling and evaluation, as some proportion of residents are moving between rotations weekly rather than transitioning 12 or 13 times a year. The data in pediatrics, while earlier on than internal medicine, really shows similar results. In a longitudinal study of the 5 original pediatric X+Y programs, residents reported improved perceptions of continuity and ability to see patients for repeat visits over the first 3 years of implementation, reductions in the impacts of the schedule on inpatient workflow and handoff quality, and improved amounts of teaching time in both the inpatient and outpatient settings. This study also gathered data from faculty with really similar results, including improved patient continuity, more time to teach, and fewer impacts of the resident schedule on workflow and overall time on a rotation. One of the main perceived benefits of the X+Y scheduling model amongst residents and residency applicants is the impact on well-being. Levels of burnout in pediatric residents nationally continues to be high, with the most recent Pediatric Resident Burnout and Resilience Study Consortium reporting over 53% of residents experiencing burnout. Pediatric residents also report little to no support in scheduling personal and mental health care appointments, which impacts their overall well-being. Additionally, 17% of residents nationally report inadequate protected time to participate in structured learning. While the direct impact of X+Y scheduling on improved well-being has been harder to quantify, multiple studies, including in pediatrics, report perceived improvements in well-being, which is attributed to increased predictability, elimination of long stretches of inpatient time, decreased cognitive load, again, from switching back and forth between inpatient and outpatient activities, consistency with Y-block peers, and the ability to build community within a larger program, built-in longitudinal time for career exploration and projects, and easier scheduling of meetings and appointments. Unfortunately, we do not yet have data looking at improvements using validated burnout instruments on an individual program or national level. With all of this in mind, in July of this last year, we transitioned our residency program to X+Y scheduling using a 4+1 model. What this means in practice is that our residents are divided into 5 Y-week pods, because we love our whales, and each of these pods share Y-weeks time. Every 5 weeks, a pod of residents has a dedicated Y-week where they spend 2 full days in continuity clinic, have a protected half day of in-person didactics together, and a dedicated half day that can be used for personal appointments, mentorship and coaching meetings, and longitudinal projects or study time. The other 2 days each week, they have a variety of longitudinal curriculum experiences, which include time dedicated to the mental health and advocacy curriculum, time in adolescent medicine and developmental pediatrics clinics as senior residents, and other individualized experiences based on the resident's specific interests. While we are still really early on in our transition and continue to refine each component of this curriculum, we have heard similar benefits and challenges as those reported in the literature from our trainees and faculty, and really look forward to continuing to work on further refining each of these experiences. Okay, now that we've discussed how X plus Y scheduling really imagines the structure of residency, let's turn now to how we can ensure that structure genuinely supports learning, specifically through competency-based medical education and stronger evaluation and feedback systems. Competency-based medical education, or CBME, recognizes that learners progress through the educational process at different rates within and across competencies, and our current system poses significant challenges for managing and supporting this known variability between learners. At its core, CBME requires robust, longitudinal assessment that enables faculty to accurately determine the developmental progress of an individual learner and then help that learner through frequent feedback, coaching, and adjustments to individualized learning plans. Currently, there are two main separate but related evaluation frameworks that exist within undergraduate and graduate medical education: milestones and entrustable professional activities, or EPAs. Unfortunately, there continues to be different and often really poorly defined constructs regarding readiness for graduation, board eligibility, and safe and effective care without supervision, or what we would consider true practice readiness, which is the ultimate goal we are trying to achieve for each of our trainees. Ideally, the requirements for each of these things should be assessed using the same principles and requirements. The reality is that that is not our current state, with inconsistent types and quality of data being collected, who that data is reported to, and if that reporting system is used for certification decisions, or if it's just another helpful tool for assessing an individual's progress in their career. I think we can all define and identify many barriers involved with designing perfect systems for evaluation and feedback. However, we no longer practice within a system where attendings and residents are on service together for multiple consecutive weeks, and we need to consider ways to shift our perspectives on the impact even one encounter can have on a learner's growth and trajectory. As medical educators and pediatricians, my guess is that we can all agree on these two fundamental assumptions. One, that all children deserve general pediatricians who can deliver safe, effective, and high-quality care. And two, that we need to ensure that all graduating pediatric residents can competently perform the tasks and activities of a general pediatrician without supervision. Unfortunately, data suggests that we're not routinely graduating residents who are ready to perform the activities of a general pediatrician without supervision. This data comes from a study recently published in Pediatrics, where Schumacher and colleagues described entrustment levels for over 2,200 graduating pediatric residents, and only 31% of those residents were deemed ready for unsupervised practice in all 17 of the general pediatric EPAs. Additionally, there was not a single EPA where over 89% of graduating residents were deemed ready for unsupervised practice. While there are many factors, including the quality of data that comes in to inform these decisions, the results of this really large multi-institutional study suggest that we're not routinely meeting these two goals as well as we would hope. In order to understand where and how we can improve, it is important to understand the types of activities and skills that we are currently assessing. So the ACGME milestones have been developed and continuously refined since about 1999, and the first pediatric-specific milestones were developed in 2012 as a joint initiative between the ACGME, the American Board of Medical Specialties, and the American Board of Pediatrics. And the most recent version of the general pediatrics milestones was published in 2021. Currently, residencies and fellowship programs are required to provide biannual reports to the ACGME on milestone levels for each trainee. Residency programs may also receive milestone information from medical schools, and milestone information may be shared with fellowship programs. Importantly, both of these things after the match is completed. Importantly, the primary use of milestones is meant to drive improvement in GME programs and enhance the resident and fellow experience. They are intended to help learners and programs improve educational assessment and accreditation processes, and this data is not available to ACGME review committees. So as you can see here, this data is not meant to impede or affect certification decisions. Milestones are narrative descriptions of knowledge, skills, attitudes, and behaviors that describe the progression of a physician through each of the 6 core ACA-GME competency domains seen here. Each core competency is then divided into sub-competencies. In addition to the general pediatrics milestones, there are specific milestones for each pediatric subspecialty and combined program. As an example, and I think this comes from radiology, not from peds, this is a milestone within the systems-based practice core competency. The subcompetency is system navigation for patient-centered care. Each milestone subcompetency is then described on a continuum of ability from novice or level 1 on the left through expert clinician or level 5 on the right. Descriptions are provided for each level, and examples of expected activities or skills are also included. While milestones serve as developmental benchmarks that describe how a resident is progressing through competencies, they often feel really abstract and difficult to fully assess and measure. In contrast, entrustable professional activities, or EPAs, are meant to be real, day-to-day units of work that are practice-based and bundle multiple competencies into a single task. Supervisors are meant to decide how much supervision a resident requires to perform these activities safely. No, I say safely. This is not, would they do it exactly how I would have done it? It's, was this safe for the patient, and was it an acceptable treatment plan? This really makes EPAs ideal for workplace-based assessment, as they're aligned with what residents are actually doing in their clinical settings. Importantly, EPAs bring the patient into the assessment equation and provide the clinical context that is necessary for a meaningful assessment. Starting in 2028, the American Board of Pediatrics has announced that they will require programs to submit data on EPAs for each graduating resident in order to inform initial certification decisions, which makes the development of effective and robust evaluation systems no longer just ideal, but essential. Programs need to ensure that they have high-quality data to inform these really high-stakes decisions, and that the assessment systems proactively promote fairness and mitigate bias. So these are the current general pediatric EPAs. They were just revised earlier this year and thankfully consolidated down from 17 to 12. And the EPAs really include tasks that apply to specific patient populations, like providing preventative care for children of all ages or caring for the newborn before discharge, as well as clinical and non-clinical tasks that are important for all patients, including recognizing a severely ill patient and providing initial management, and leading members of an interdisciplinary team to provide collaborative, family-centered care. The goal of training is for trainees to be able to perform these activities with less and less supervision over time, ultimately achieving that goal of practice readiness. EPAs can also be used to give feedback to trainees with a focus on growth and development, keeping us focused on the big picture priority of safe and effective patient care. Both EPAs and milestones are important in the overall assessment of a learner's progress and inherently assess different parts of the larger picture, with milestones often representing that zoomed-in task, with EPAs zooming out to the larger patient care activity that requires multiple discrete tasks to be completed simultaneously. So unless you think about this every day like I do, this is likely clear as mud. So I'm going to give you a non-medical example to demonstrate the interplay between competencies, milestones, and EPAs. The competencies and milestones that are needed to drive a car include things like, can the driver control the steering wheel? Do they have good judgment? Do they know how to change lanes? Do they know the rules of the road, and can they apply them? All of these skills are important to perform the activity, which in this case is to safely drive a car. Using our current medical education model of assessing and reporting milestones, we would assess each of these competencies and milestones and make this determination. But how many of you would be happy if teenagers never had to demonstrate their ability to safely drive a car before obtaining their license? Instead, there would be a series of data about how well the teenager could do the component pieces. One would likely argue that even if they demonstrated that they could perform each of those different competencies, you would not know if they could actually put it all together safely without actually assessing whether they could, in fact, drive a car. While this is somewhat dramatic, I think that it makes a pretty strong case for why assessing the EPA, in this case, whether the teen can safely drive the car, rather than just the individual competencies and milestones. Okay, so let's bring it back to a medical example. Let's start with the EPA of care of a child with an acute common problem, and more specifically, nail this down to care of a child with pneumonia. The question we want to answer is, can the resident care for the child with pneumonia presenting to clinic without supervision? If we were in clinic precepting a resident, we likely are able to say yes or no to that question. And if the answer is no, we can further delineate how much supervision we feel was needed. Did we just need to answer a quick question, or did we need to be there for every bit of the interaction? Additionally, if the answer was no, it is critical for us to define why. Is it because they're struggling with taking a history and physical? Is there a gap in medical knowledge? Are they struggling with organization and prioritization? Or is there a communication challenge? Identifying where our growth opportunities exist then allows the educator and their learner to focus on the steps that are needed to further develop this skill. While all of this sounds great in theory, we can all recognize the very real challenges that exist within our current systems for feedback and evaluation. Our current assessments are long, are completed well after a trainee has finished a rotation, and involve using clunky systems like MedHub. Additionally, skills and activities that we are tasked with assessing are often not effectively assessed in the clinical settings where our trainees are working. And perhaps most importantly, we as educators really have difficulty accurately identifying specific gaps and providing feedback that is helpful for the growth of the learner. Despite these challenges, we as faculty are still expected to provide feedback. Ideally, feedback that is growth-oriented and focuses on the shared goal of achieving the skills of a general pediatrician. In their updated program requirements, the ACGME continues to highlight the importance of feedback and evaluation, stating faculty members must directly observe, evaluate, and frequently provide feedback on resident performance. They go on to describe the role of formative evaluation and providing feedback that can be used by the residents to improve their learning in the context of provision of patient care or other educational opportunities. Despite this charge, according to the 2025 ACGME survey, 28% of pediatric residents are dissatisfied with the feedback that they're getting from faculty, leaving lots of room for improvement. While we know that feedback happens in many different venues and situations, for better or worse, we also depend on written evaluations as a proxy for assessing if feedback is happening. You can see here that the overall number of evaluations completed for our residents over the last several years. And this number is low, especially when you consider our large residency size of 136 residents across 3 years of training. My very conservative estimates, i.e. plugging numbers into a calculator, of the number of attending evaluations that should be issued for each rotation type per year show us that this issue crosses all environments and levels of learners. From rotations completed once by each resident during their training, so adolescent medicine, developmental pediatrics, to our senior-only rotations like PICU, and our inpatient rotations. Based on these estimated expected evaluation numbers shown in red, which, like I said, is almost certainly an underestimation, this means that at most 50% of the expected MedHub evaluations are completed for any given rotation, and in reality, this number is likely closer to 25 or 30%. Our data also shows that of the small proportion of evaluations that actually are completed yearly, a total of 25% in academic year 2024 for reference, almost half were completed over 40 days after the evaluation was issued. While we always appreciate the effort, evaluations that are completed this long after a resident has completed a rotation leave little to no room for meaningful discussion and limit the opportunities for growth, which is particularly important given the time-limited nature of residency. Luckily, people smarter than me have started to think about how we can more effectively collect useful data in a more timely fashion. The Society for Improving Medical Professional Learning, or SIMPLE, is a nonprofit collaborative working to continuously improve the medical education system by providing access to an evidence-based platform for trainee feedback, assessment, and case logging. The SIMPLE platform for assessment was initially developed to enhance workplace-based assessments in the surgical fields in 2013. Since that time, over 450 graduate medical education programs have started using the platform across 28 specialties in 6 different countries, and in total, over 1 million assessments have been completed to date. Based on one study's findings from 400 evaluations, each assessment took on average 27 seconds to complete once an assessment was created, albeit these were surgeons, so they might be a little less verbose than we, but still can be done. Perhaps more importantly though, the studies have shown that the quality of feedback provided in the form of workplace-based assessments in SIMPLE was significantly more likely to be effective than the feedback provided in traditional end of rotation evaluations. literally 58% effective in simple and just 11% in those end of rotation or med hub evaluations. So as encouraging as the surgical data is, it is important to acknowledge that surgery is inherently different from pediatrics, and the skills needed of a general pediatrician require different types of assessment than the technical skills of surgery. Fortunately, Simple has been modified to address these differences, and with sponsorship from the American Board of Pediatrics, is now being piloted in general pediatrics and pediatric emergency medicine programs nationally. Our residency program is participating as one of almost 100 pediatric programs across the country that are implementing this easy-to-use assessment tool focused on obtaining routine, frequent EPA assessments by frontline faculty, you all, that can then be used to inform decision-making and summative assessment at the program level, us. Since launch in late August, we have collected over 300 frontline assessments, with 69% of our residents having at least one assessment. So anywhere from 0 to 11 for our residents, which is awesome, in 5 different clinical spaces. While we are still really early on in the phases of this pilot, it does seem to be working. We have officially rolled out use in hospital medicine, newborn nursery, continuity clinic, and the ED. And as you can see here, after only 13 weeks, we have over 200 assessments completed on inpatient teams, which compares to just 500 total completed evaluations in the entire academic year, 2024, in the same setting. So now I'm going to hand it back over to Hannah to talk about how each of you can continue to support and enhance our training, education, and learning.
Thank you, Elena. We're now going to talk about some concrete steps that each of us can take. So big picture, there are a number of policy changes that could make pediatrics more financially viable and secure. And while I acknowledge this is a hard environment for any of these to occur right now, I think it's important for us to remember what we are targeting in the long run. First, Medicaid-Medicare parity is really key. Medicaid covers about 40% of children, but reimburses at roughly 2/3 of Medicare rates for the same services. Since most pediatric patients that we see in the hospital have Medicaid, this payment gap disproportionately affects pediatricians and our salaries. Similar discrepancies in payments actually also occur at the GME level and influence our ability to develop pediatric programs the way we envision. Additionally, CMS assigns RVUs in a way that underrepresents pediatricians and undervalues the care we provide, impacting how all insurers pay us. And importantly, loan support is really key as we work to get our salaries in a better position. New limits on federal education loans reduce access to public funding, which will increase the amount, most likely, of private loans that med students have to take, which are not eligible for public service loan forgiveness. Additionally, while Congress passed the Pediatric Specialty Loan Repayment Program, it has never been fully funded. Beyond these, and I do encourage everybody to get involved with the AAP, and that there's really amazing advocacy toolkits that can help to easily get involved in these important matters. Beyond these pieces, there's a lot of local opportunities to get involved in pediatric med ed. It's important that we increase pre-med and med student exposure to pediatrics. Data suggests that pediatrics is a sticky field. People who fall in love with pediatrics stay in love with it. You can sign up to be a pre-med mentor or to have pre-meds or med students shadow you to get those early exposures for people to have the opportunity to fall in love with this special field. Similarly, this is something I'm very excited about because I want it as an outpatient-focused doctor, and I think a lot of our residents would also benefit from it. The X+Y model has created the opportunity for us to strengthen resident exposure to your specialty fields pre-fellowship. We're working on a new pilot to pair R2s interested in a particular subspecialty with an attending who works in that field. Our goal is to have them join you in your standard clinic about 1/2 day every 5 weeks or during their Y week over a year. We're hoping that this pilot will allow for strong mentorship relationships to form and increase residents' confidence and skills for fellowship, and also will help to address some of the fellowship recruitment numbers that we discussed. There's a link here, a QR code, and come talk to me because I'm very pumped about it. And then there's a lot of things we can do in our day-to-day as educators. We are always, as a team, looking for rotation and site med ed champions. You can work with your division and hospital to set up pre-med observerships or revamp your electives or enhance the inpatient experience for trainees. We are looking for people to help us build asynchronous learning materials for core topics, given that high trainee rotation that Elena discussed, and our res execs are happy to partner with people to help out with that process. Additionally, we're looking for help with improving our trainee assessment and feedback systems in your area. We would love to bring Simple to your team, and Elena is super excited to talk to you about it. We're also looking for help in redesigning our MedHub evaluations to be more useful and relevant for your clinical area. And then I think most important is just to keep doing what you're already doing and showing up. We consistently hear from our residents how much they love getting to interact with you, know you, learn from you, and how much they want you to get to know them. There are so many ways to get involved with trainees here, from teaching on rounds, mentoring, attending a morning report, including them in your research, or coming to many of our events. Additionally, one of my great joys in residency recruitment is getting to be inspired daily by the stories of the incredible people entering our field. These quotes are pulled from personal statements that I've gathered just this past week. What matters, what you do, I consistently hear matters, and people notice. Our patient notice the beautiful care you provide, like this one person who talks about Dr. X became a trusted family member. From Dr. X, I learned the value of longitudinal care. Pediatric patients notice the care you provide, and they grow up to be medical students and one-day residents. Additionally, our med students notice the small thing you did that had a huge impact. Like this med student who writes about, I knew I wanted to be like my hem-onc attending who brightened the patient's day with a bubble machine. And additionally, our residents, I know notice, sorry, my voice is really giving out now. I still very clearly remember when Dr. Susan Marshall brought me to her office as an intern to talk about a patient who had made a decision to move towards comfort care. It's not hard to connect the dots between me being an undifferentiated med student or resident on an intern to now being a pediatric palliative care provider and APD. And so I'm forever grateful for that, as well as so many other people. And when I read these accounts of the huge impact you all have had on trainees, I think about a quote Dr. Alyssa Darden, our program director, has on her wall as a guiding mission for us all. It's from Hamilton. Legacy, what is a legacy? It's planting seeds in a garden you will never get to see. Recently in clinic, I met an incredible young man and complimented his mom on raising such a person. She said, my dad says he was raised in a good garden. I've reflected a lot on that praise. As a parent, there's nothing more than I want for someone to say that about how I raise my kids. But it's also really impacted me in how I think about being a pediatrician and an educator. Our trainees are incredible people who will be incredible pediatricians, and our job is to be good gardeners for them, to create an environment that makes their journey easier, brighter, more nourishing, so that they can fully flourish. And I believe that when we advocate for better reimbursement, mentor a resident, show up to morning report, care for our patients with compassion, or teach with enthusiasm, we are being good gardeners. And I'm grateful I get to see that all every year in the applicants you all bring to us. So thank you. So anyway, thank you for your time today. Thank you to my incredible palliative care family who shows up for me so much. Thank you. Special shout outs to our entire GME team, including our fearless leader, Dr. Alyssa Darden, our co-APDs, Drs. Crystal Perez, Tracy Seamers, Molly Groh, all of the GME and UME leaders who all deeply contributed to this work, and to our med students, our fellowship students, everybody. And just in case we need a reminder of how great our Y is, these are our amazing residents that we center in all of our work each day, and it's such a joy to get to learn from them all the time. And we hear our references, and we would love your questions. Yeah, we read a lot.
Thank you so much. I'll turn around and look for hands.
Hi, Scott Pagano, community pediatrician. I can't help but notice when I look, we, in my old program, also did X plus Y, we implemented 6 plus 2. But I can't help but notice, to me, the difference in valuing general pediatrics education between having to go a half a day, 36 weeks a year, versus going 2 full days once every 5 weeks. And to me, though the numbers seem somewhat similar, the value of general pediatric education seems less when you only show up twice every 5 weeks for full days than when you're having to go half a day at least 36 times a year.
I think that point is well noted, and I think is something that continues to need to be an area of study. Originally, the X plus Y model, when it was rolled out in internal medicine, was like a full week of clinic. That unfortunately, until the ACGME continues to further refine their requirements, there's just not enough time to fit in all of the different requirements over the course of the 3 years of training. And so I totally think that is something that we've talked about. I know Molly has talked about as our continuity clinic lead as well. And I think it's something that is really important to keep an eye on and focus on to see if that is impacting, because we routinely send 40 to 50% of our residents into primary care. And so if we are seeing changes in that, I think that will be important to note. Thank you.
Maybe if I could give a quick follow-up to that, I think you raised a really important point, and one other plug for our program that is different than almost any pediatric residency in the country is that all of our second-year residents spend actually 2 full months embedded in primary care in some rural practice setting around the WAMI region. And so that opportunity of 2 full months of living the life of a general pediatrician, I think is a great way to sort of get exposed to the field.
So one other piece with our pilot, an idea we've had for our residents who are thinking about becoming general pediatricians is also potentially using that pilot to offer an additional exposure to a different style of clinic, to acknowledge that there's so much variety in general peds and some people want additional time too.
Molly, Elena, and Hannah, thank you so much for really just such an interesting presentation and going so deep into so many different areas in a short period of time. I wanted to just follow up on your, Elena, your plug for Simple, just to say to folks that, in addition to, if we learn to do this well with our residents, we're also doing the exact same thing right now with our medical students, right? So the medical students that you're seeing who in clinic or on the wards show up with their QR code and ask you to do a work-based assessment, they're asking you for that, just give me feedback on one simple thing that I just did right now to help me improve. And it's the exact idea is what y'all are trying to accomplish in Simple. And hopefully if we can all get in the habit of doing the same thing, regardless of the level of our trainee, we'll be more effective at providing that kind of feedback.
Thank you. There's a few questions from online, so I will get to those, and then you guys can raise your hands some more. From Jason Dean, are there data regarding med-peds programs either benefiting or hurting pediatric residency matching numbers?
Yeah, there is data. I at one point had a slide and then made myself delete it because there was just too many. I think overall they're not hurting us, but they're also not successfully compensating for the loss we're seeing in pediatrics. So there are more, it does help us overall that they are getting pediatric training there, but I don't think it's a competition between the two. I think it's pediatrics everywhere in all forms is having a hard time recruit people.
Dr. Rivara, if you can hear my voice, you can unmute and ask your question.
Thanks very much. Can you hear me?
Yes.
Great job, Hannah and Elena. I have a question. Like in the New York Times yesterday, there was an editorial by Zeke Emanuel and some others from Penn suggesting that we should shorten medical school to 3 years. And we know that adult subspecialties have a 2-year fellowship, and pediatrics seems to be stuck in a 3-year fellowship. Do you want to comment on the time of training, and would that be a way of helping recruit more people into medicine, into pediatric specialties?
And Dr. Rivara, I'm happy to hand the microphone to you as the ultimate expert on these pieces. I think that there's a core tension, like Elena was pointing out, that some of the numbers suggest that we're not fully training people to the degree we're hoping for in our current model. And so I think if we're going to be shortening time, we also concurrently need to be thinking about how we're ensuring we're reaching the same bars that we were before. When I look at the fellowship data, as someone who did a straight clinical fellowship, I see a lot of opportunity to potentially tailor fellowship tracks for people who don't want as much research time, but would still be able to have a lot of clinical time. And that there's some data that helps to reduce the like the negative impact of doing a fellowship for some of our pediatric subspecialties in terms of getting people to their career a bit faster. So I think that there's a lot of room for such ideas.
I can add from the CBME standpoint, I think there's, the true CBME like gurus out there will say that we should be doing this. We should be having variable amounts of training for everyone based off of their individual needs, which is cool in theory, next to impossible in actual practice. And so I think thinking about that too has played in, and I know there's been, some studies out there that are looking at shorter courses of medical schools and doing more of that CBME based graduation from school, but it doesn't change when the residency cycle starts. And so I think from both perspectives, that's playing a part for sure. And I agree with Hannah. I don't know that shortening our core time is the answer, but I do wonder about the specialty time and whether that could address especially some of our needs outside of our academic settings.
Thanks very much.
Dr. Walker, I see your hand up. If you can hear me, you can unmute and ask your question.
Sure, thank you. I'm sorry, I had to go in and out, so the question I'm asking could be have already been answered, but I want to thank you so much for highlighting this, and thank you for highlighting AMSPDEC. Our workforce initiative really is looking hard at all aspects of how to improve our numbers, interest, sustaining careers in pediatrics. One of the things that we found is that residency by medical school, right? People have made a decision, and so we're looking at how do we actually begin even earlier that pre-medical school, medical school, to help give people an opportunity to see what's available in pediatrics. And I'm curious how you would see our department, our residency program, fellowship program, kind of working to help stimulate people's interest, reinforce it. Sometimes people say, "Oh, why are you going to peds? You're like a really good medical student." How do we counteract that things that we hear? And do you think there's a role for residency and departments of pediatrics to kind of reach back into medical school?
I absolutely think so. When I think about my own journey to this career, it started with a mini medical school for high school students, and thinking about the opportunity to have pediatricians in that setting to highlight the important work we do from early on, I think is a really key area we can get involved in. Having people sign up for the UW program to have pre-meds shadow you, be mentored by you, I think is huge. Elaine and I were actually sharing the many things were told to us as med students when we were thinking about pediatric careers, including exactly those kinds of lines. And when I think about, I was a very undifferentiated person and forever will be, but I am a pediatrician because of Dr. Lee Atkinson McAvoy. I can tell you exactly who it was, and she was an incredible mentor for me as a med student, and just somebody I was like, you are a badass and I want to be you. And so anytime I would hear those things, I would think back to, she is brilliant, so obviously pediatricians are brilliant. And so I think that one-to-one connection still really matters and carries huge weight.
I think we underestimate how important our words are. And when we say something like, "Oh, you want to be a pediatrician," or "You could do something else," right? We could change how we say that. We could encourage people and say, "Tell me more. Why are you thinking that? What makes you interested?" We can cultivate it in them because, the dean of my medical school looked at me and said, "Well, you're too smart to be a pediatrician." And I said, "What?" Why on earth would you say that to somebody? And I think that we need to remember that and think about it instead of just knee-jerk reacting to something that may surprise us. So
one other thing I've been reflecting on is obviously it's always mattered for myself that I had a career that felt good and was sustainable, but it has taken on a new urgency for me as I look through these numbers to be living out in my daily life a job that when a resident asks me about it, I'm like, I have the best job ever. I think that is something that like I'm trying to cultivate in myself in terms of how I think about my daily practices. And it always should have mattered just for me, but there is this extra motivation to reach that for myself, to be a good role model, and to show that there is a really great job to be had in pediatrics.
I'm so glad you all and we all decided to be pediatricians. Thank you so much for all your work and all your time. Thanks everyone for being here.